Once clinical symptoms appear, rabies is a 100% fatal disease. But if we follow the correct immediate medical protocol, it is entirely preventable. When a patient arrives at the clinic with an animal bite, time and exact precision are our absolute priorities. Today, we are walking through the complete standard operating procedure for intake, assessment, and treatment, the clinical foundation of the state's Rabies-Free City initiative. Before you even see the patient, ensure your station has the required toolkit ready: running water, soap or detergent, an antiseptic like povidone iodine or alcohol, the anti-rabies vaccine, and rabies immunoglobulin. Having these specific tools at hand and executing every step of this procedure exactly as written ensures the patient will have zero risk of developing rabies encephalitis. Let's begin. Step 1 is the single most important action in the entire process. You must immediately wash the wound under running water using soap or detergent for a full 15 minutes. Once the full 15 minutes of washing are complete, apply povidone iodine. If iodine is unavailable, an alcohol-based antiseptic must be applied to the wound. Patients often arrive having applied local home remedies like lemon, chili powder, turmeric, or coffee. You must firmly advise against this. These harsh substances push the rabies virus deeper into the local nerves, accelerating the path to the central nervous system. This procedural document clearly outlines what you cannot do. Immediate suturing, wound cauterization, and tight bandaging are strictly forbidden without prior and proper prophylaxis. This thorough washing physically destroys the viral envelope before the pathogen can travel from the wound site to the central nervous system. Now that the wound is clean, we assess the exposure. Note that while dogs, cats, and jackals are primary rabies vectors, bites from non-vector animals like bats, rats, squirrels, and birds do not require rabies prophylaxis. This official exposure table dictates our next steps. A Category 1 exposure involves touching, feeding an animal, or licks on completely intact skin. This requires only thorough washing. No vaccines are administered. A Category 2 exposure includes minor snarches or abrasions where there is absolutely no bleeding. For this, we wash the area and proceed with the anti-rabies vaccine. A Category 3 exposure is any single or multiple transdermal bite, a scratch that draws blood, or an animal lick on broken skin. This mandates washing, the vaccine, and the immediate addition of rabies immunoglobulin. Take your time during assessment. Missing a tiny drop of blood and incorrectly logging a Category 3 wound as a Category 2 means the patient misses out on critical immunoglobulin, a mistake that frequently leads to protocol failure and patient mortality. For active immunization, the World Health Organization recommends the intradermal route over the intramuscular route, as it offers higher vaccine potency. Looking at this vaccination schedule, the intradermal regimen dictates exactly 0.1 milliliters administered in both deltoid muscles. The patient must return on days 0, 3, 7, and 28. If using the alternative intramuscular regimen, you will administer one entire vaccine vial into the deltoid across 5 visits, days 0, 3, 7, 14, and 28. Next is passive immunization, or rabies immunoglobulin. This step is mandatory for every Category 3 patient, as well as any Category 2 or 3 patient who is immunocompromised. This protocol guideline explicitly lists the required weight-based dosages. Equine immunoglobulin is dosed at 40 international units per kilogram, and human is dosed at 20. This volume is infiltrated directly into and completely around the wound. There is a strict time limit here. Immunoglobulin must never be administered more than 7 days after the patient's very first vaccine dose, because their own antibodies will have already begun forming. The vaccine takes time to build systemic immunity. Infiltrating immunoglobulin into the injury bridges that gap, providing the immediate, localized defense required to survive. Occasionally, a patient will return with a new bite, claiming they have already been vaccinated. You must require official documentation of their previous doses before you modify your treatment plan. This decision tree outlines the re-exposure pathways. If the official documents prove they received a full vaccination course within the last 3 months, you only need to wash the wound. No new vaccines are required. If their documented vaccination course was completed beyond 3 months ago, wash the wound and administer the vaccine on days 0 and 3 only. Strictly note that no immunoglobulin is needed. However, if the patient claims prior vaccination but cannot produce documentation, treat them immediately as a brand new, unvaccinated case. Relying on a patient's memory leaves a margin for error. When documentation is absent, executing the full standard protocol is the only safe medical fallback. By successfully executing these steps, washing, categorizing, and delivering the correct immunizations, the immediate threat is neutralized. The patient is completely protected for today, but remember that the full medical treatment loop is not yet closed. Ensure you hand the patient a clear, written slip detailing their exact mandatory follow-up dates for the remaining vaccine doses on days 3, 7, and 28. Finally, officially log the complete treatment details into your local clinic registry. Strict, unwavering adherence to this SOP saves individual lives while fulfilling our frontline role in the state's rabies-free city initiative.